So what are the different types of contraception that we can use, and what are the potential impacts on patients? So for each type of contraceptive, we'll go over just quickly the mechanism of action and then maybe some considerations. So if someone comes to you, like a client comes to you to train, what are some things that you might need to be aware of? So the first one we have is the oral contraceptive pill, which I'm sure everyone has heard of. We've got the Depo-Provera injection, the implant, IUDs, and emergency contraception. So starting off with the oral contraceptive pill. So the classic one is the combined oral contraceptive pill. For example, this one up here, Levlin, and it's a combination of estrogen and progesterone. In New Zealand, this is the only contraceptive that has estrogen in it. All of the rest of them either have no hormones or are progesterone based. How it works is it prevents ovulation. There are a mixture of active pills and hormone pills throughout the month, so that in the 4th week, everyone can choose to either take the sugar pills for a week and have a withdrawal bleed, noting that it is not a period, it's a withdrawal bleed, or they can choose to what we call run their packs together, which is when they just have one active pill every single day. After chatting with medical, that is generally a perfectly safe thing to do. It can really help with a lot of period type symptoms, and it actually works a little better as a contraceptive that way too. For those who cannot take the combined oral contraceptive pill because of the estrogen in it, then they've got the option of taking the mini pill. So we've got an option up here, which is Noriday, for example, and one down here, which is Cerazette. Now, these both, of course, only have progesterone in them. There is no active or hormone tablets. It is just one progesterone hormone tablet every day. How it works is that the Noriday and other types of mini pill generally change the cervical mucus. The Cerazette down below works effectively like a combined pill. It does prevent ovulation as well. Some things to think about. You do need to take this at the same time every day, regardless if you're overseas or on exercise or deployed. You need a script every 6 months, maybe a little sooner if people are running their packs together. And they need to see a doctor probably every year for a renewal of their script. The combined pill has a window of 12 hours to take it, and the mini pill, like Noriday, has a window of 3 hours to take it. What that means is if you normally take your Levlin at 7 a.m., you've got until 7 p.m. to take it, otherwise you're risking a pregnancy. Irregular bleeding is not uncommon, particularly when stopping it, and can be seen on things like the Noriday as well. We've spoken about how it can help with period symptoms and PMS type symptoms as well. With the combined pill, because of the estrogen, there is a small chance of blood clots, so in the leg or in the lung. There is a small chance of an increase of heart attack and stroke, and a very small increase in the risk rates of cervical cancer. Generally, that fades away after someone stops the combined pill. It can help reduce the chances of endometrial, ovarian, and colorectal cancers. The combined pill is not suitable for people who have a history of migraine, particularly with aura, if they're over 35 or if they are smokers. The Depo-Provera is the injection. This is given roughly every 3 months into one of the buttocks. It can be given by a nurse or a medic, and then aiming to see a doctor about every 12 months for a renewal of the prescription, noting that it can be a little bit tender after it's been given. It lasts around 13 weeks, but there is some leeway if someone is getting their bleeding back a little bit earlier. It's not uncommon to get some irregular bleeding when it's first started. After that, around 70% of people get no periods, which is generally perfectly safe. Weight gain is one of the common concerns with the Depo. Generally, most people are fine. There is a higher risk if someone starts off at a BMI over 30, or if they gain more than 5% of their body weight within the first 6 months, we would probably recommend changing to something else. It can also affect bone density. This is particularly important around the time of perimenopause and menopause, so really not a suitable contraceptive for that time. For those around the time of puberty, we know that once people, or in the early 20s, we know that once people stop the Depo, that those issues with bone density resolve. The last thing to think about is I wouldn't recommend this if someone was planning to start trying for a family in the next 6 or 12 months. Generally, if people miss their 13-week appointment, they're at risk of pregnancy, but very occasionally it can take 6 or even 12 months for fertility to come back. Then we move on to what we call our LARCs, which are long-acting reversible contraceptives, or fit and forgets. So the first one to talk about is the implant, or the rods, or in New Zealand it's called Jadel. So these are 2 rods around the size of a matchstick. The insertion process is very, very simple and straightforward. You get a small incision around the size of a grain of rice. You get some numbing lidocaine injected as well, and then the rods are inserted. After the insertion, they probably won't have a stitch because the wound is so small, but they will have an open wound and bandage. And then after removal, there might be a stitch because the wound is a little bit bigger. So just keeping that in mind in terms of upper body workouts, and we want to avoid excessive sweating under the dressing and the risk of infection. How it works is that it thickens mucus and it might prevent ovulation. We know that it's effective for up to 5 years, between 4 and 5 years. The biggest kind of side effects that people might come across with the Jadel is irregular bleeding. We do have medication to help with that, particularly while it's trying to kind of settle in. Then we move on to our next LARC, or long-acting reversible contraceptive, is the intrauterine device. So IUD, not IED, and this is another fit or forget. So this is a small device, so smaller than our palm there, that is inserted into the womb. And it works effectively by preventing the sperm from reaching the egg in the tube, and also from any fertilized embryo from implanting within the lining of the womb. They can last anywhere between 3 and 10 years, depending what type is put in. There are 2 types. There is the copper, which is completely hormone-free. That can make periods a little heavier and a little more painful, particularly when it's started. And then the other 2 options are hormonal-based options. They generally help quite a lot with periods in terms of drastically reducing the flow and the pain associated with periods. I do insert these at Whenuapai, so I know, of course, that the insertion can be uncomfortable, but we've got ways of managing that. It's not uncommon to have some crampy type pains for up to around a week after the insertion, and can get some bleeding for a day or 2 as well. The risks of an insertion going in, a small risk of infection, so there is a patient information sheet I provide to try and reduce that risk afterwards, and a very rare complication of a uterine perforation, which is effectively a damage to the wall of the womb. Going over quickly the emergency contraceptive. So I think we've probably all heard of the emergency pill, or the morning after pill, which can be taken up to 3 days after unprotected sex, but is much more effective the sooner that it's taken. The copper IUD is also an emergency contraceptive. It can be used up to 5 days after unprotected sex, depending on where someone is in their cycle. It's actually a much more effective form of emergency contraception, and of course it provides ongoing contraception if someone wants to continue with it. And then lastly, just touching on non-hormonal contraception, there is fertility or cycle tracking. So some people only have sex at certain times of the month. It is not a very effective contraception. It's got at least a 25% failure rate. It is very labour intensive, so people need to monitor several factors every day, including temperature and discharge. And then lastly, condoms. When used as a contraceptive by themselves, the success rate is around 85% with typical use. But of course, they're the only contraceptive available that helps prevent us getting STIs. So really important to use that in addition to something else that can prevent pregnancy.